Welcome to the Jewish Theological Seminary. My name is Rabbi Berk Visotsky, and I am the director of the Louis Finkelstein Institute for Religious and Social Studies. And the Institute has, since 1938, brought wisdom to the community, both from the religious and other spheres. The Institute was founded by Margaret Mead, Reinhold Niebuhr, and Louis Finkelstein. Just the three of them alone would have been sufficient. But they brought their friends, and we have been doing these kind of programs ever since. I am particularly honored to do this program tonight because as an educational institution, we feel a strong obligation to educate the community about medical issues. But because of who we have here tonight, we also literally have the opportunity to save lives and encourage people to be tested. And I am grateful to my colleagues for being here. I do a lot of interreligious dialogue, and I don't know if you know the cutting edge of interreligious dialogue, but the most recent ritual we have in the interreligious dialogue world is this. Please turn off your cell phone. Apparently across religions, everybody agrees that's a good thing. Once the panelists, individual panelists have spoken, we will be handing out index cards and those little pencils. It's not for you to record your golf score, but for you to take the opportunity, either from the individual talks or as the panelists talk amongst themselves, to write down questions, hopefully in legible handwriting. And then Cornelia Dalton, my programming coordinator, and I will be collecting them from the outside rows so that we have a clear camera line, and you will in that way have the opportunity to ask questions of the panelists. Immediately following the panel, we have two things going on. On this side, to my right, Letty Cottin Pogrebin, one of our panelists, is going to be signing and selling her book, How to Be a Friend to a Friend Who's Sick. I have read this book more than once, and it's just full of wonderful advice, compassion, and wisdom. And we're selling it at discount. Second of all, as you leave, or as you came in, you see that we have a lot of information out there, information on the before study and how to register for the before study if you have not yet been tested. There will be someone there, and there is information there also from a Jewish organization called Sharsheret, which particularly deals with women's cancers. So we're happy to have this ability following the panel as well. I want to welcome everyone who is watching via live stream. We have live streamers from across the United States and Canada, and when I say across, I'm saying hi to our friends in Vancouver, because I know we have a group there. The evening's discussion is going to be framed and moderated by my esteemed colleague, Rabbi Lisa Gelber. Lisa came to me a number of months ago and said, this is a program you simply must do. And I've learned over many, many years that when Lisa says that, I do it. And I'm really grateful to her for bringing it to me. Rabbi Gelber was ordained by the Jewish Theological Seminary and served here at JTS as our Associate Dean of the Rabbinical School. She is currently the Rabbi of Congregation Habonim on New York's Upper West Side. Lisa herself is a cancer survivor, and appropriate to some of our panelists, she's also a long-distance runner, and really a beloved colleague. Rabbi Gelber, please.
Thanks to everyone for being here, especially to Dr. Visotsky and to JTS and the Finkelstein Institute for Religion and Social Studies for hosting us this evening. Tonight, we have the opportunity to hear some very important information, reflection, and personal testimony about risks of cancer and BRCA genes. We have four amazing panelists this evening. Dr. Ken Offit, who is the Chief of Clinical Genetic Service at Memorial Sloan Kettering Cancer Center. In 1996, his laboratory team discovered the most common BRCA2 mutation among Jews of European ancestry associated with an inherited risk of breast, ovarian, prostate, and other cancers. We have Dr. Miriam Levy, who is the founder and medical director of Medical Imaging of Manhattan, which is a radiology practice specializing in women's imaging. Letty Cottin Pogrebin, the founding editor of Ms. Magazine, the author of 11 books, most recently, as Dr. Vysotsky said, How to Be a Friend to a Friend Who's Sick, and the novel Single Jewish Male Seeking Soulmate. She is a breast cancer survivor and is going to be speaking from a very personal perspective. And Dr. Michael Bergstein, who is a double board certified ear, nose, and throat and facial plastic surgeon with ENT and Allergy Associates. And he just finished recently an Ironman triathlon. So we have amazing wisdom and physical and emotional and spiritual strength here this evening. As Dr. Vysotsky mentioned, after each of our panelists have the opportunity to speak, and I'll introduce each of them in course with a title that will help direct the conversation that you'll hear. After they speak, we're going to have the opportunity to be in conversation with one another in your presence, and then we'll have time for questions and answers. Again, you'll have these cards that you can write down your questions. Please make sure that they're questions so that we don't have to reformulate them for you. And also to be clear, no one is going to be answering any personal medical questions this evening, so not to put those on there as your question. I want to take a moment to mention one of my favorite American Israeli singers, Achinoam Nini, who goes by the name Noah. She has an amazing album, if we still use the word album, called Jeans with a G and Jeans with a J. The title track on the album, and here she is here with her jeans in here, right, with a G and a J. Her title track reads in part as follows. Can I wear your jeans? Guess that's not my choice. I'm walking down the street and singing in my mother's voice. When you reach this world wet and cold and scared, little do you know what you'll be forced to wear. When you grow and change, eyes are open wide. You can try in vain to metamorphosize. But can I wear your jeans? So these words are really at the heart of this evening. 1 in 8, some people say 1 in 9, 1 in 10. This percentage of women will be diagnosed at some point with breast cancer. And it's important to remember that this cancer is not more common among the Jewish community. However, those of Jewish ancestry have 10 times greater risk of inheriting the mutations of the BRCA genes, right? So if the general population carries these gene mutations at 1 in 400, then in the Ashkenazi Jewish community, we can say that 1 out of 40 carries these gene mutations, which puts us at greater risk of breast, ovarian, and prostate cancers, among other cancers. 90% approximately of the carriers of these mutations, these BRCA mutations, have no idea that they are BRCA positive. They don't know what they're wearing when they walk around, right? They don't know. And so part of this evening is to learn about the BRCA Founder Outreach Study. If you saw it outside, if not, you'll see it later. I'll hold it up here. Everyone in my synagogue has seen this countless times over the past many months. The purpose of this study, among other things, is to expand knowledge about the BRCA mutations, to motivate people, and to give access to testing in the Ashkenazi Jewish community. The idea being to empower people, that when we have knowledge, we can take action that can save lives. I say that as a rabbi whose job is to translate Jewish tradition. And I say that as somebody who carries the BRCA2 gene mutation. And I say that as a breast cancer survivor. I was tested and found out that I was BRCA2 positive, and I decided I knew my own constitution. I know who I am. And for me to wake up every morning and say, oh, I'm wearing these jeans, I can't take them off the way I would take off my pants, I can't do this, and I'm going to have 2 prophylactic surgeries. And as those from my Kehillah, from Congregation Habonim who are here know, that once I made that decision, I decided that I would prepare for 2 prophylactic surgeries. And it was in the preparation for bilateral mastectomy that I found out that I had breast cancer. I had absolutely no idea. I had had a mammogram 2 months before. There was nothing there. I had absolutely no idea. So it was my testing and my decision to face that knowledge and awareness and say, I want to live, and I'm going to do everything I can to not have to deal with cancer that actually saved my life. We wear our genes every day, right? You can't take them off. So the attention to what makes up our body, that genetic makeup, is actually the same as any attention we would give to our physical and our spiritual well-being. It is the knowledge and the awareness and the investment that we place in who we are as a human and our work in the world and being here to do that work in the world that can really make a difference and save lives. And that's why we're here this evening, so that we can find ourselves empowered through knowledge, and we can share that. Because I'm going to ask that everybody who is here this evening goes home and sends 2 texts and makes 2 phone calls and 2 emails. 6 things to do when you leave here tonight, so that you can share what you learn with 6 other people and help transform their lives as well. So it's now my pleasure to call on Dr. Ken Offit, who is going to share some words on cancer risks in Jewish individuals, what they are, and how to find out.
So we'll set this up, and to first, of course, thank Rabbi Vysotsky and Rabbi Gelber, and to mention to some of my conspirators in the back, Robin Baum. We always wonder, we do these outreach events, and thank our distinguished panelists who you'll hear from, physicians. I'm speaking as patients. Me is sort of the instigator of all of this with the discoveries. And when we have these small groups, I sometimes say to Robin, couldn't we just have one giant meeting in Madison Square Garden or something and just do this? But what you've just heard, and Robin knows what I'm going to say, from Rabbi Gelber, that's it. You don't need to hear anymore. We can all go home now, okay? And this is why you have rabbis, right? Because she wrote down what she was going to say, she thought about it, and has a personal connection, right? And so there's nothing that I can say that is going to come close to approaching the power of what you've just said. And I'll just say that right off the bat. And the message, everything that was just said, every word that you just said is the kernel of what we wanted to accomplish tonight. And you did it all, 100% of it. And what I'm going to do is I'm going to ask each of you for sort of a little personal piece of information, maybe in the next couple of minutes after I've told you a little bit first. But the bottom line is that, as we were joking with Rabbi Vysotsky about an evangelical, this is sort of an evangelical event. And this applies to everyone listening in online and on the stream too, because we have a major challenge in front of us, and I'm going to talk to you a little bit about it. So you've heard one personal testimonial. Here's another personal testimonial that your kids probably won't learn in high school. Too bad, they should. They'll learn that Watson and Crick won the Nobel Prize, but they won't learn probably about Franklin, who's shown on the lower left, Rosalind Franklin, who actually should have. It's not. Oh, I see. It's not showing. All right, so we'll see what we can do here. That showing now? Yep, you can see that, right? And we're going to that. You got it now?
Yeah.
Comfortable? Okay, I'm on AV Guy also. So Rosalind Franklin, you may know, most of you know Rosalind Franklin, right? She did the X-ray diffraction studies that when you read, or actually you can speak, Watson's still very much alive, and he will tell you that this led to their zeroing in on the helical structure of DNA. She did not win the Nobel Prize. She was a woman. She also was an Orthodox Jew. And she died of ovarian cancer early in her life and wasn't around to sort of make probably the case. This is another story of a physician who goes into an emergency room in London who had a little abdominal ache. And she was giving a talk like I just gave a medical talk, and they told her, to their horror, that on the CT scan that they did in the emergency room in London, that her little ache was caking peritoneal metastatic ovarian cancer. This was my wife's best friend in medical school. She was the head of a major department in academic medicine. I won't say where, in a major center. And I had been socially friends with her during the whole course of our lives. You know, our kids kind of were the same time and grew up. And for those of you not able to see this, I'm just showing a picture of a pedigree that just shows a person in a family without a big medical history. You can see there that her mother had breast cancer, but you don't need to be a specialist to see that that's not a big family history. But she never asked, and I never asked much about her medical history, and she could have gotten genetically tested, but she didn't. So if we had tested her, if she had said to me during one of our many breakfasts and social outings with our kids, you know, my mother had breast cancer when she was young, and, you know, I can get tested. And had we tested her, had we tested Rosalind Franklin, what would we have done to save her life, this woman at age 56, who now had a BRCA mutation we would have found, and died later of metastatic ovarian cancer? What would we have done for her? We would have done a hysterectomy. We would have done a preventive ovarian surgery, right? And then we would have had a 4% chance of finding a microscopic cancer. And despite some views that ovarian cancer always forms in the fallopian tube, it doesn't, okay? It commonly has origin in the fallopian tube. But in cancers we found, you'll see small ovarian cancers in the ovaries as well. And those tumors are cured if they're taken out early. And we rarely have the opportunity. I never saw stage 1 ovarian cancer at Memorial Sloan Kettering until I started doing BRCA testing. And we wrote this in the New England Journal of Medicine in 2002. So that's what we would have done. We would have done the surgery. Now, whether you take the ovaries and the tubes, or whether you take the uterus, the hysterectomy, those are nuances, okay? The bottom line is that the ovaries and the tubes would have saved the life. So the fact or fiction about is cancer more common? We were talking about this at the dinner that the rabbi was hosting, and I was correcting this incorrect notion that breast cancer is more common in Israel than it is in the United States. It isn't. So breast cancer is not a Jewish disease. There are some cancers that are more common in Jews, but they don't have very much to do with BRCA mutations. I won't tell you if you want in the question period. I could tell you, but I won't tell you now. But not breast cancer. But what is more common is the hereditary basis of cancer in Jews. And I discovered a number of mutations other than the BRCA2 mutation in Jews that cause different kinds of cancers because we have a greater burden of hereditary cancer. Which is interesting, isn't it? Right? So this is just written out in word form. Hereditary cancers are more common in Ashkenazi Jews, but the specific cancer types are not. And for those watching it, I'm just showing word slides of what I'm saying. Now, this will be hard for the people listening in. And this is, when I teach this to medical students, genetic counselors, PhDs, doesn't matter. this is how we do it. So there's a certain graphical flavor to this. So to describe this in words is hard, but for those listening in, if you have a rare mutation that happens, say, in 100 people, a mutation happens. And mutations happen generally when there's a moving part that gets broken. So if you've got a complicated machine with a lot of moving parts, one will break occasionally. And in the mutation that I found, for example, in BRCA2, the sequence of the gene in the region where the mutation occurs is GACTTTTACT, so a multiple of these T's. And if I were to ask those of you to dictate that to the guy next to you, the odds are that one of you is going to go GACTT and forget one of the T's, and you'll miss one. And it's going to happen if you've got a repeat like that. And that's what happens, right? So one of them just gets forgotten in the course of the normal replication of DNA. And that one missing T is all you need to have a disaster, which is this very high risk. So that happened randomly in one woman or man, we don't know, could have been a man, living in a part of the world, and you can see what the little map is. And for those of you listening in, I've drawn a map of Poland to try to fool the few folks here in the room. And then what happens is the population's not 100 anymore. Now the population is decreased, and I've used that word in sort of an interesting verb. I've made it into an action, like is decreased, which is to say murdered, shrunk, persecuted, okay, pogromized, which isn't a verb, but you know what I mean. The population decreases so that there aren't 100 now. There's only 5 Jews left in the world, and one of them is this unfortunate man or woman who had this rare 1 in a million event. But now it's not 1 in a million, now it's 1 in 5, because there's only 5 left. Now you come along and somebody named Catherine the Great says, stop killing those people and let them alone. But they can breed, but only with themselves. Got it? Now your 1 in 5 mutation is 1 in 5 as the population increases in size. Okay? So this is a bizarre experiment. This wouldn't go through your IRB ethics committee, but it happened on the planet Earth. And this is now I'm showing a slide of the Jewish population through history. This is an amazing slide. So this shows that around the time of the Romans, I learned from the rabbi that a lot of Jewish religion was taken from Roman customs, so we have an anthropological perspective on things. So Ashkenazi, as you know, means German in Hebrew. So what the Jews did is they went north with the Romans is they assimilated. And so the number of Jews in the population of about 4.5 million at the beginning of the Christian era decreased. Decreased initially not because of the killing. It's just flat out assimilation. But then, after the settling in the Rhineland, then the persecution begins. And what you have in Jewish history, and this was surprising to me, is a series of population-threatening events that happen extending all the way from about the 2nd to 3rd century AD up until 1700. So the Jewish population, the Eastern European Ashkenazi population in Europe, was near extinction for centuries. 20 to 30,000 is the lowest point of the numbers of the Jews in Europe. It's incredible, isn't it? And it was in very small population areas in the Pale of Settlement. And so we had these events. And then, of course, when the plague happened, the whole population decreased, but the Jews got blamed for the plague, as you know, because of kosher practices. So that made it worse for them then. Couldn't win, okay? But survived. And so these founder mutations, the one I discovered and many others, happened at different points in Jewish history. The one I found happened relatively late with the split of the Ashkenazis and the Sephardics that happened in 1492. But there are some mutations, like one I found that causes colon cancer, that happened so early that I've actually I've seen members of royal families of certain Middle Eastern countries who I've had translated into Arabic that they have a Jewish mutation. In fact, we were in Haifa last week, and I was telling stories with my Israeli colleagues who thought that was extremely fun, because they don't get a chance to see Arabs of the royal family. But I do, because they come to the United States, and I take care of them at our institution, okay? Do you follow the irony of that? So it's a Semitic mutation, you know. It's Ibrahim, you know, Abraham. I mean, they're not that different, you know, look alike. Genetics is actually quite similar. Okay, so that's the Pale of Settlement. I'm showing a picture now of the Pale of Settlement, and now I'm showing a picture of the of the Helsinki massacres, and these are the BRCA founder mutations. Okay, so that's it for your cultural history. So we have BRCA mutations. They're present in men and women. Now, at this point, I've told you some kind of personal things. This is a voluntary question. You do not have to answer this, only if you feel comfortable, and you can just raise a little pinky if you've already had BRCA testing. Just a little indication if you would like me to know that, okay? So thank you, and you don't have to say it. No. So about a third of the people here are already conversos, okay? So, and I don't mean that in that sense, okay? So, but listen, for those of you who have had it, the Rabbi Gelber's message, that's why you're here, okay? You're getting powered up to go home and get other folks motivated to do this. For those of you who haven't been tested, why to be tested? So we've talked to you about the BRCA testing. This is what a typical family looks like, and you'll notice in the pedigree, for those at home, I'm showing a pedigree family history tree that shows a man with a mutation, and I'm showing the man having prostate cancer and carrying the mutation. And I'm also showing a man getting breast cancer, which most people don't know happens, but does happen, because men who carry the mutation get breast cancer, and the men get prostate cancer, and you'll be hearing a lot more about that later. And then I'm showing the slide of the mutations, and I'm showing this Jewish mutation. These are the papers 20 years ago. And now I'm showing the slide about what can you do. So you'll be hearing more about it. The most important element you'll be hearing from Dr. Levy, which is, this is a mammogram. This is a breast cancer and a BRCA mutation kit. This is the cancer that's found on the MRI. And I'm married to a radiologist too, so I'm careful to say this is a nipple, so don't take that off. That's cancer. MRI. This field of radiology has revolutionized our management of women at high risk. It's a tough test to have. It's a tough test to interpret. But the sensitivity of this test is it is in the order of 80 to 90% compared to 30 to 40% in this age group for women having mammograms. MRI, magnetic resonance imaging of the breast. And you'll hear more about that. We're going to have a whole talk about that. But I'm just introducing these. Angelina Jolie, of course, got everybody thinking about prophylactic mastectomy, but we don't do that much prophylactic mastectomy for BRCA2 mutation carriers, interestingly, as we do for BRCA1. In this country, probably 20 to 30% of individuals will elect to do the safest thing, and the rest will put their trust in the hands of our radiologists, okay, who will do a great job and find a cancer early. We are counting on it, okay? But some women would prefer not to meet the radiologist or me or Memorial Sloan Kettering and not get breast cancer. And the psychological satisfaction among women that do preventative surgery is off the charts, okay? It's very, very high, and it's remarkable. I mean, they feel very, very empowered by this procedure. But it's not required, okay? You can have breast-conserving treatment, and that's the art of medicine. You have to figure out, what camp are you in? Are you in the camp that's going to be nervous every day or not? And we spoke already about the ovarian surgery, and we're going to talk in detail about prostate cancer screening if you're a man that has it. So I'm just introducing these topics, and I've told you about now why to have the test. One thing I didn't mention here, I'll mention just because it won't come up, is that you can also, if you have a BRCA mutation and you're very young, have children that will not have a BRCA mutation by doing assisted reproduction, which is an amazing thing. It's not science fiction, and we do this. So you can have a child through IVF, and we can guarantee it so that the child you have, and you can pick the gender, will not have a BRCA mutation. That's interesting, and by the way, this was taught to me by Israelis. Okay, they do a lot of IVF in Israel for reasons we can talk about in the question and answer period. Okay, so why should we do it? Rabbi Gelber's already said this, so I'm just repeating that 90% of folks don't get this information, and a lot of people don't want to hear about this information, which is what I hope all of you listening in will help us with, okay? And we do need to do more testing. So you can simply go online to b4study.com, sit through a whole lot of stuff, which you've got to endure to get through this study, listening to me on tape and my colleagues from Harvard, and you think I'm long-winded, Harvard, Penn, and Cedars-Sinai, sign a consent form, go to a local Quest lab, and get the test. You have to be over 25, have one grandparent who you think was Jewish, okay? For this study, you have to be in New York, New Jersey, Boston, Philly, New York, New Jersey, Boston, Philly, or LA. So those listening in Canada tonight, because I know there's a big congregation in Canada, you can't be in this study. Stephen Nayrod, are we listening in Ottawa? In Vancouver. Okay, so Vancouver's a little far afield for I know the geneticist, like MD PhD, who runs the work, actually trained in my lab. The Canadian system will not pay for universal BRCA testing for Ashkenazi Jews. So if you're in Vancouver, you're going to have a friend or relative in one of the major cities until we get this thing set up in Canada, which we're hoping to do in the next couple of years. No cost for the testing. So far, we're into the study with over 2,000 participants, and you can see the accrual by location. I'm showing a slide of New York, Boston, Philly, and LA, and that there's still time to enroll. And I'll just mention that we'll stop this current study probably by the early part of next year, and then we'll be going to a phase for the second part of the study, and we can talk about that in the question and answer period. And then I just wanted to mention that this is a multi-institutional effort. I'm sort of the instigator, but Beth Carlin, who is on the Harvard Board of Overseers, a presidential appointee, a major figure, is working on this. Judy Garber, president of the American Association of Cancer Research, Nadine Tung, he's just elected into the academy as well, and Kate. So we've got a group of folks who are dedicated to making this study go forward. And here it is, the b4study.com, and we'll switch to the next speaker. Thank you.
Thanks very much to Dr. Offit. Our next speaker is going to be Dr. Miriam Levy, who will speak about how to screen for breast and gynecological cancers for those at high risk.
Get the computer off. Hello, everyone. It's an honor to speak to you about a topic that's so close to my heart. I want to thank Rabbi Bert Versatsky for inviting me and Rabbi Lisa Gelber for making this important event possible. I grew up in a shtetl in the neighborhood of Borough Park in Brooklyn, where there were 3 taboos that one could never talk about: sex, money, and cancer. Since then, I strayed from the shtetl, widened my horizons, and changed some of my core beliefs. After medical school, residency, fellowship, and working in a multi-specialty radiology group in which I was the only woman physician, I founded a women's radiology practice called Medical Imaging of Manhattan, where I'm still the medical director. I wasn't trying to be an entrepreneur, but simply wanted to practice women's imaging in a different way than was customary. My aim was to give women the respect and attention they weren't often getting, while providing a high level of diagnostic accuracy and sound medical advice. So I wound up spending my professional career hunting down cancer in women's sexual organs while being a business owner, thus overcoming the 3 taboos from my life in the shtetl. And that's why I'm able to talk to you tonight about Jews and cancer. I'm going to focus on radiologic screening for breast and gynecological cancers for people who are genetically at risk, because those are my areas of specialty, and apologize for leaving out other organs. Let's start with breast cancer. There are 2 basic types that are being diagnosed: invasive breast cancer and DCIS, ductal carcinoma in situ. The invasive type meets the classic definition of cancer. It has abnormal cells that multiply in an uncontrolled fashion while infiltrating the breast. Left untreated, it becomes life-threatening when it travels through the bloodstream and lymphatic channels invading other tissues around the body. DCIS is a group of cancerous cells lining a breast duct that have not attacked even the first layer of cells adjacent to it, and therefore does not cause anyone any harm. In fact, sometimes it fizzles out. Nonetheless, there are dangers with DCIS. Some will develop into an invasive cancer, but we're not sure how many and which kinds. Also, there could be an invasive cancer nearby or in the opposite breast that can't be seen on the initial mammogram. I think DCIS should be reclassified as a high-risk lesion, requiring some treatment and close monitoring, but sparing many from the anxiety and emotional trauma a diagnosis of cancer can bring. I'm in the minority. For women who have a BRCA mutation, the lifetime risk of contracting breast cancer is 70%, while for the general population, it's about 10%. The cancers they develop are often more aggressive and present at younger ages, and there's a 40% risk of developing cancer in the opposite breast. Unless a woman decides to undergo prophylactic bilateral mastectomies, and by the way, I think that's a perfectly reasonable choice, our best chance of protecting her is to perform very thorough screening exams on a regular basis, because when we detect breast cancer at its earliest stages, many lives are saved and the treatments are shorter and simpler. So these are the breast cancer imaging exams that radiology has to offer. First and foremost is mammography. It's a dedicated 2D X-ray of the breast utilizing low-dose radiation. It's the gold standard for screening and has been shown in numerous large-scale studies to produce a 30 to 40% reduction in deaths from breast cancer compared with women who aren't screened. The greatest challenge is that of breast density, which has nothing to do with the way the breast feels. Breasts are composed of glands and fat. Fat appears gray on a mammogram and is easy to see through. Glands show up looking white, are hard to see through, and called dense. The denser the breast, the more glands compared to fat. Since breast cancer also looks white on a mammogram, it's harder to detect it in a white background than in a gray background. It can get camouflaged, and when that happens, it's called a false negative mammogram. Additionally, layers of dense glands often overlap one another on a mammogram and can look as if there's a growth that doesn't really exist. And when that happens, it's called a false positive mammogram. Next are several studies that can help overcome the breast density issue. Recently, they've developed a new kind of mammogram called DBT, digital breast tomosynthesis, or 3D mammography. Rather than showing a single image of the breast with all of its contents superimposed, it separates it into very thin slices, similar to CT scans and MRIs. It's much more accurate than standard mammograms, finding twice as many invasive breast cancers, remember those are the life-threatening ones, and has significantly fewer false positive results, avoiding unnecessary extra images and biopsies. There are a couple of things you need to know about DBT. The FDA requires that when performing a 3D mammogram, 2D images be acquired as well, and that doubles the radiation dose. Several years ago, special software was developed to take all the digital information embedded in the 3D images and use it to synthesize or reconstruct that data into 2D images. The synthesized images are excellent, and I insist on using them instead of getting a second mammogram. Make certain your facility has that software and does the same. Here's another issue. Since we can find tiny invasive cancers on 3D imaging that can't be seen with 2D mammography or any other imaging modality, specialized equipment was developed to perform needle biopsies of the breast utilizing this new technology in order to get an accurate tissue diagnosis. Make sure your facility has the capability of performing 3D guided needle biopsies of the breast, because the usual kind of breast biopsy performed with 2D technology will not suffice. The next modality is ultrasonography or breast sonograms. It uses high-frequency sound waves to produce images. It's very good at finding invasive cancers inside dense breast tissue, is able to distinguish fluid from solid tissue. It allows the examiner to image areas at the periphery of the breast and beyond that can't be seen on a mammogram, and doesn't expose the patient to X-rays. The downside is that it's very dependent upon the user and the reader, and in many centers there's a high false positive rate. I have to say that's not true of our practice. We've utilized ultrasound as a supplement to mammograms for 3 decades, especially for those with dense breasts, women who are at high risk for breast cancer, women with implants, and those who have chest deformities. By adding the sonogram, there was an increased diagnosis of invasive breast cancer of approximately 30% over that of the mammogram by itself. Now that we're doing 3D mammograms, the contribution of ultrasound has lessened, but it still finds some invasive cancers that can't be seen on any other modality. The next one is MRI, magnetic resonance imaging. It uses a very powerful magnet, radio waves, and computer technology to produce a series of thinly sliced images through the breasts. It requires an intravenous injection of a substance called gadolinium that highlights, or in the vernacular, lights up, cancer in the breast. MRIs have a very high level of sensitivity for finding breast cancer, the ability to distinguish fluid from solid tissue, don't expose the patient to X-rays, produce images that include the peripheral tissues better than a mammogram, and in excellent anatomical detail. The disadvantages are that they're very expensive and take a long time. People who are very claustrophobic can't tolerate them. They're not safe for those who have certain metallic devices implanted in their body, and the gadolinium injection imposes some small risks. Rarely there's an allergic response, and in the last few years we found out that gadolinium, especially with multiple repeated injections, stays in the brain. Now, gadolinium has been used for about 30 years in MRIs, and there have not been any reports of any ill effects to the brain so far, but it's actively being studied. Also problematic is that MRIs are less accurate in younger women and those on hormone replacement therapy. That's because hormonally active women have a lot more blood flow in their breasts, sometimes causing much of their normal breast tissue to light up. The results can be both a camouflage effect and false positive findings that lead to unnecessary MR-guided biopsies and follow-up studies. The last 2 exams are MBI, molecular breast imaging, also known as miraluma, and PEM, positron emission mammography. Both can increase the cancer detection rate, but require an intravenous injection of a radioactive substance that gives too high a dose of radiation to the entire body to be reasonable choices for screening. So now that you're armed with all of that background information, here are the current recommendations for which screening exams to get and when to get them. For women with BRCA mutations and their untested first-degree female relatives, the American College of Radiology recommends an annual breast MRI beginning at age 25 and annual mammography, either 2D or 3D, beginning at age 30. My recommendations are slightly different. Both an MRI and a breast sonogram should be done annually, but timed 6 months apart. The annual mammogram should be a 3D exam with synthesized 2D images, scheduled at the same time as the breast sonogram, because the 2 in combination are very powerful. With this plan, you're checked twice a year with multiple modalities, each of which could find a cancer that the others can't. So before you start scheduling exams, I'd like to educate you about the quality of care you get in radiology. It depends upon the excellence of the equipment used, the skill of the technologist and or radiologist performing the exam, the diagnostic skill of the radiologist interpreting the exam, and the judgment and wisdom of the radiologist who decides what to do about a radiologic finding, whether to leave it alone, get immediate extra imaging, and what kind, ask the patient to return in 6 months for repeat images, or recommend an image-guided needle biopsy or a surgical biopsy. Also very important for finding early, subtle, and tiny cancers is having 2 radiologists review each exam. That's what we do in our practice. Simply put, 2 pairs of very skilled eyes are better than 1. A little bit about men now. Male BRCA carriers have a lifetime risk of developing breast cancer that is significantly higher than that of the average man, but lower than the average woman. There currently are no guidelines for regular screening for men who carry those mutations. It's all done on a case-by-case basis. I hope we'll learn more about what to do for men soon. The next topic is screening for gynecological cancers. The organs at very high risk are the ovaries and fallopian tubes. In fact, it's now believed ovarian cancer begins in the tubes. I know Ken feels differently, but a lot of people feel it does. The uterus is usually spared, not always, except secondarily when being treated for breast cancer with the drug tamoxifen. BRCA1 carriers have a lifetime risk of ovarian cancer of 44%, while for BRCA2 carriers it's 17%. Testing with sonograms, CT scans, or MRIs is very helpful when someone has an abnormal physical exam, symptoms, a known tumor, or is sick. However, studies have shown they're not very effective when people have no symptoms and a normal physical exam. Ovarian cancer tends to grow very rapidly, doesn't cause symptoms until much later on in progression, and often can't be caught early enough with radiologic screening to change the course of the disease and the treatment. The standard recommendation is laparoscopic surgery to prophylactically remove the ovaries and fallopian tubes by the ages of 35 to 40 for BRCA1 carriers and 40 to 45 for BRCA2 carriers, hopefully after they've had children if they choose to. Clearly, this poses very significant physical and emotional challenges for younger women. Clinical trials are underway for removing only the tubes. The results aren't out yet, but it looks promising. Additionally, putting women on birth control pills for at least 10 years lowers their risk by 40%. For those who have their ovaries, the recommendation for screening is a transvaginal sonogram along with a CA-125 blood test every 6 months. I want to conclude by saying that with all of my years in the field of medicine, I'm always learning new information. When there are compelling studies and innovations, I change some of the ways I practice in order to do better for my patients. At the same time, the more I learn, the more I'm humbled by what medicine doesn't know. I'm very hopeful that Dr. Ken Offit and others like him will shed more light on the very significant problems people with BRCA and other genetic mutations have and how to best help them. We need you, Ken, and I hope that many of you will sign up for his before study. Each one of us needs to be our own best advocate for our health, and getting informed is the key. Thanks.
Thanks to Dr. Levy. I'm sending everyone to her practice tomorrow. Now we'll hear from Dr. Michael Bergstein. BRCA screening in men, is it worth the effort?
Thanks, everyone, for having me. So Brian's my friend. Brian is a physician in our area. Brian and I share patients. He's an internal medicine doctor. I'm an ear, nose, and throat physician, head and neck cancer surgeon. Brian and I share patients. Brian and I share beers. Brian and I share a child who has some disabilities. And one day, Brian relates to me, that he's been having some back pain. And, Brian's athletic and I'm athletic. We all have some back pain from time to time. The back pain gets so excruciating that he presents to the emergency room. And they do an MRI. And Brian has metastatic prostate cancer. Brian's 46 years old. Brian, over the course of the next 3 years, goes through treatments that are difficult to talk about. His family goes through the same treatments in terms of the discourse that they have from day to day. And Brian then asked me if I've gotten tested. I'm an otherwise healthy 50-year-old physician. I have a full life, I have a full practice, I have a full family. Never quite occurred to me. So I go get a blood test. I get a PSA. And my PSA actual level is normal. And I don't really do anything about it. Now they say that a physician who takes care of himself has a fool for a patient. And that's true. So I go for my routine examination with my internist. And he says, Mike, I know that your blood level's normal of your PSA, but I'm looking at it, and even though 4 is the recommended normal level, yours is 3.6, but only a couple of years ago it was 1.2. I said, okay, what are you saying? He says, I just think you should go get checked out. All right, fine, I'll go get checked out. So I go see a urologist, and the urologist says, well, I know your level's normal, but it has been going up, and let's do a biopsy. Okay, we'll do a biopsy. I don't think really anything's wrong with me. Not long thereafter, I get a phone call one Sunday morning, and I find out that I have prostate cancer. I've got this full active life. I can't have prostate cancer. But I do. So even though Brian had experienced this, and I'm a physician and I treat cancer, it's very different when it's yourself. You don't internalize it. There's a lot of denial that goes on, and certainly denial goes on with my patients as well. And so the denial extended to, I'm just going to get this out and we're going to move on. And so consequently, I went to the local urologist. Did not come to Memorial Sloan Kettering, which in retrospect was a major mistake because of this denial, and I ended up having surgery. Well, because of my haste in wanting to get rid of my cancer and not really paying attention, turns out that my cancer was still in me after my surgery. The thing about the surgeon who did my surgery was that what he said to me was, I said, wait a second, we just did a cancer surgery and I still have cancer. As a cancer surgeon myself, the object of the cancer surgery is to get rid of the cancer. But I still have cancer. My surgeon's retort to me was, it's really the size or the width of a hair. It's like being a little pregnant. What do you mean? I still have cancer. Well, yes, but you're going to die of something else. This is actually one of the mantras of urologists and physicians who refuse to test patients, is that you're going to die of something else. This prostate cancer is not going to kill you. And that's a myth. And I know that because I only have to read the obituaries of the New York Times to see how many people, how many men die of prostate cancer. So one of the things that you want to do when you choose a physician is you have to have a physician who is not only competent in his abilities, but compassionate in his services to you. And if you can't find them, then you go keep looking for one who's going to understand you and what you go through. A Consequently, he recommended that I just observe this because the likelihood of me developing cancer again that is going to go throughout my body is going to be minimal. And I sort of was left to figure this out on my own. I ended up speaking to some nationally prominent radiotherapists who said, well, the amount that he left is not really the actual width of a hair. It's substantially more than that, and after much consternation and second and third opinions, I decided that I would get radiation therapy. And there were certain risks of radiation therapy in and of themselves, and it was going to be elective and something I chose to do. What I didn't realize is that by not getting radiation therapy, if this cancer returned, I was done. There was no other alternative treatment. So my surgeon, who left me with cancer, was now playing with my life because he suggested observation and not treatment with radiotherapy, and didn't even quite explain to me that we were playing Russian roulette, because if he was wrong and the cancer did come back, my life was over. So I elected to get the radiation therapy. I will say that I trained for my previous Ironman with my radiation therapy, which was a little crazy, but nonetheless, that's what it did. And I'm approximately now 3 years out from my surgery and my radiation. And thankfully, my PSA is 0. And I get checked 3 to 4 times a year with significant trepidation every time I get my PSA, because that is my life and death sentence. Now, there are some cancers that you can't avoid and you can't help. And I see that in my practice as a head and neck cancer surgeon. God forbid you get lymphoma. You can't help that. Or leukemia, for that matter. Or by and large, pancreatic cancer. You cannot change what that is going to happen, if that's going to happen to you. But you can find out if you have prostate cancer. And the silliness of the recommendation of the American College of Surgeons to not get screened, to see no evil and hear no evil, and I don't want to know about it. And if we do get your PSA and it's abnormal, what are we going to do about it anyway? We don't know whether you should have surgery, we don't know whether you should have radiation, we don't know if you should have watchful waiting. So wait a minute. So we have a test to determine whether or not I have cancer, but we're not going to get it because we don't know once we get the results what we're going to do about it? Really? Shouldn't that be my choice? And so it's incumbent, regardless of what your internist says to you or your urologist says to you, to get your PSA checked and let that be your choice. And you do the research, and if God forbid you have cancer, then you make the decision because it's your life, not your internist, not your urologist. So where does BRCA fit in? Well, if you're BRCA positive, the cancers are significantly more aggressive. When we talk about patients who have prostate cancer and watchful waiting, those patients are not BRCA positive. Those cancers can be indolent. But if you're tested, and if you are positive for cancer, and you are BRCA positive, that cancer's behavior is not the same as it is for the general population. What does that mean? That means it is there's a Gleason score. And typically more indolent cancers are Gleason 4, 5, and 6. But we know from research that if you are BRCA positive, that you're starting at the minimum of 7, which means that if you don't get treated, your prostate cancer will definitively kill you. So the BRCA testing is extremely important for your life, and if you're going to deny and you're not going to get screened, and you're not going to do this for yourself, then consider your children. Consider your family. Not what they're going to do when you're not there, but you are responsible singularly for the life and health of your offspring. And if you don't get tested, then you are possibly condemning your children to die of cancer unnecessarily. And again, because of what I do, I know that people will deny it. They don't want to know about it. But the fact of the matter is that we can find out through a PSA and a BRCA test what potentially is going to change the lives of your child's life and their offspring as well. So my message is to get tested for your BRCA, get your PSA, and if this is, again, not about you, this is about them. And so what I've hoped to do today is bring you a professional surgical perspective and a personal perspective about my experience with cancer as well. So thanks for your time and thanks for coming out.
Thanks to Dr. Bergstein for your wisdom and your honesty. Now Letty, Cottin, Pogrebin will offer a personal perspective on breast cancer.
So as opposed to everyone else on this panel, I don't have an MD, I have a BA in English and American Literature. I have an MS for having co-founded Biz Magazine. I am 9 years away from the fateful words, "The radiologist would like to see you." I had mammograms my whole life. I had many biopsies because I do have dense breasts. So I know the words, "the radiologist would like to see you," are different from "go get dressed, you're fine." And that was the beginning for me of what Alice Trillin, Bud Trillin's wife, called the land of the sick. My life changed. Suddenly, it's all about you. You know how we're always told, it's not all about you. Well, suddenly, it's all about you. It is all about you. And you spend your life hoping that you're going to make the right decisions and get the right information. And if you're like me, I'm fanatical about research. I'm a journalist. I got to know everything. You do a deep dive into the internet, and you ask all your friends, and because I am an Ashkenazi Jew, I have a lot of friends who've been there, done that. So I have the horse's mouth all over my life. And I go to Memorial Sloan Kettering, and my friends tell me there's nobody else. You have to go to Larry Norton. I go to Larry Norton. He makes an exception. He has stopped taking patients, but it happens he has read some of my stuff, and he takes me because he was a fan of Ms. Magazine. I write in my book about how grateful I am for the personal care I got at Memorial. I must assume that others get the same care, but I have at this point 8 different doctors at Memorial because of various other things that are being watched in my very small body. And I get spectacularly personal care, and in the advice-giving mode, I would like to definitely second the notion that you want to interview your doctors, not just because of their reputations, but whether or not you feel they're relating to you as a human being. So I end up having a good cancer. This is a really annoying phrase that many of us who've had it learn to recognize and get very pissed off at. But the reason I had a good cancer is that I had a tubular carcinoma, and I was treated with a lumpectomy and 6 weeks of daily radiation. I did not have to have chemo. In the 6 weeks of radiation, I decided I really wanted to read about how to deal with my friends, because they were really kind of disappointing me, a lot of them. They were saying ridiculous things, and they were not bringing me, and when I was in my post-surgical at-home mode, they were not bringing me presents that had any purpose. You do not need another bouquet of flowers to die on your windowsill when you've had breast cancer surgery. You don't need one of those Zabar's baskets with the cellophane all over it, full of dead pears and ancient dates. You know what I really would have liked was, for the same price as one of those Zabar's baskets, I would have really liked a massage. For the same price as very fancy Godiva chocolates, I would have liked someone to ask me what I really had a yen for. And in my case, it would have been lamb chops and brownies, because those are the things that I grew up feeling really great about. I was not a big eater, but I always loved lamb chops and brownies. And if anyone had said, you know, I'm going to bring you something, I'm going to visit you, I'm going to bring you something, it might as well be what you want, I would have said lamb chops and brownies. So in the process, as I say, of being in a radiation for 6 weeks, I start Googling friendship and illness. How do you get your friends to be more responsive, more helpful, more useful, if you don't mind my even putting it in utilitarian terms, because they all want to be helpful, and yet, you know, they miss a step. And there were no books. The only books I found were for young adults. They were young adult and children's books for how to deal with if you have a friend who's sick. This was not useful unless you were 8 years old. So I said, you know, I got to write this book. I'll write the book I wish I could read. And then I said, well, I have to be here every morning at Memorial Sloan Kettering. How am I going to report the story? I would want to get a reasonable sampling of all kinds of folks, different religions and races and backgrounds and ages and all of that. And then I looked around the waiting room, and there was my sample. There were people from all over the world come to Memorial for their treatments, and the people who come don't just have cancer, they also have heart conditions, and they've also had a kidney transplant and a number of other things. So I turned to the person next to me in the waiting room, and I said, I'm writing a book about how to be a friend to a friend who's sick. Have your friends been helpful? And of course, immediately I get a story, and in the case of my reporting, anecdotes are evidence. Anecdotes are evidence because they if you drill down, they tell you about the person and the friend. They tell you what was useful and what wasn't. And I had kind of categories of usefulness and not useful. For example, what do you say when a friend of yours first says, I just got a horrible diagnosis? Well, you don't say what was said to me, which was, well, if you have to have a mastectomy, at least you're married. This is not useful. This is not a useful sentence. It didn't make me the least bit comforted. Someone else said, oh, my aunt had it, as if somehow or other their aunt's experience was precisely mine, or she's precisely like my body. Or, well, at least you got it early. They didn't know if I got it early or didn't get it early or what it means to get it early. The second category is visiting. People come and they think, you know, I have schlepped all the way out here from, you know, Bayside, and it took me 40 minutes, therefore I ought to stay 40 minutes. No, you don't necessarily stay 40 minutes when someone is just out of surgery or when you're visiting them in the hospital. You have to be sensitive to what point they are in their extremis. People told me, for example, that when they were in a hospital bed feeling miserable and nauseous, the worst thing was a person who came with coffee breath or who came with garlic breath and sits on the edge of your bed as if you don't have a scar that an edge of a bed sit really can aggravate. Or someone will stop by on their way to yoga in their yoga clothes and you feel, I'm never going to be well again, I'm never going to be healthy again, this is going to ruin my life, and somebody comes bounding in the full bloom of health. The presence that people have told me they get was something as similar as a man who had a broken leg, a very serious broken leg, and somebody brought him a bottle of scotch, which was really nice to heal from a broken leg, but the person forgot that the guy was a recovering alcoholic. So you're a cancer patient, but you're also a full person with a history and a biography and a set of other kind of characteristics that become relevant or don't cease to become relevant. Also, I do not want to hear ever again, you look great. You look great is a sign that you really look awful, and that they haven't ever told you look great before, by the way. I am not told in my normal life, 9 years out of breast cancer, I am not normally told 3 or 4 times a day that I look great. But that's the giveaway, that they really think you look horrible. I would also say, never say, oh my God. If you're a teenager and you say, oh my God is like, oh my God, I love your lipstick. But if you're my age or over 50 and you hear, oh my God, it's like, oh my God, are you going to die? In fact, several people, when I told them my diagnosis, asked me right flat out, is it terminal? Is it terminal? My advice, and it's throughout the book based on 80 interviews with people in the waiting room and elsewhere in my peripatetic life, and my own experience, I kind of distilled the message to a kind of honesty etiquette that flies in the face of everything we've been taught. And the honesty etiquette is 3 things. You have to be able to say to the person who's sick, or if you're the person who has gotten the diagnosis, you have to say to your friends 3 things. Tell me what's helpful and what's not. Tell me when you want to be alone and when you want company. And tell me what to bring and when to leave. You will be doing a mitzvah. You will be doing a good deed if you give people the tools to do what they want to do, which is to be helpful and to be a good friend. You will do them a mitzvah if you tell them those 3 things and say, you have permission to do the things that here are very, for me, very meaningful. And if you're not sure about what your instinct tells you, ask me. So I just came today from, and I'll end here, from visiting a friend who is sick. She happens to have just had a double knee replacement. But this is my rule for any sick bed visit. Any sick bed visit. I call beforehand and I say, you know I'm going to bring something. What would you like? That gives them permission to tell me. And I have been told, you know what? We've run out of toilet paper. Would you mind bringing toilet paper? Because there have been so many visitors and they ran out of toilet paper. This woman said to me, I just have such a yen for a scone. Can you find me a scone, really good scone? I went to Magnolia Bake Shop and I got her a fabulous maple pecan scone and she was really happy. I wouldn't have known to bring her that. I might have brought her a book, I might have brought her a plant, none of which she wanted. So I just leave you with the honesty etiquette. Remember those 3 things. Ask it of your friends or allow your friends to ask of you. Thanks.
It's interesting. I've been friends with Letty for 25 years, and I know what cocktails she drinks, but I didn't know you like brownies. We have about 11 minutes left. Let's spend about 5 or 6 minutes with the panel discussing amongst yourself. And then, Cornelia, I'm going to ask you to hand out cards now while people are listening to them. And if you have questions, write them down on the cards, pass them to the outer aisle, and we will collect them. Thank you.
All right, So while everyone is writing down their questions, one question is sitting with me. Everyone spoke with such passion. So my question is, how is your knowledge and your experiences, how does that affect how you now approach other people?
May I say one thing that I neglected to say, and I promised
Please.
the doctor I would say?
You can only take 10 minutes.
No, I'm taking 30 seconds. As soon as I got my diagnosis, I got tested for the BRCA gene. And anyone who doesn't do that, it might as well just be an ostrich, put your head in the sand. Having the BRCA gene test reassured me, because I didn't happen to test positive, and it reassured my daughters. If it had been negative, it would have allowed me to be a more informed patient. Simple as that.
Thank you.
I'm sorry, repeat your
No,
question.
please. So you're edging into it. How have your experiences, personal and professional, how do those affect how you interact with other people? As doctors, as individuals, as those trying to make sure that we take responsibility for ourselves and feel empowered about our health?
Well, I'll just say again, I have become a relentlessly honest person about almost everything that matters in my life. I don't fake anything. I feel that I looked into the abyss until I knew that I had a good cancer and that I was going to get through it, and I probably would live to see my next birthday. I wasn't signing 5-year warranties on a new dishwasher because I was really not sure of my future. And once I grappled with the reality, the existential reality of what was going on and what others around me were having happen, now if I meet someone who's got a diagnosis, I say, how do you feel about this? How does this make you feel? I don't say, how are you? That's a horrible question. People will have to go into an entire exegesis to tell you how they are. But if you say, how are you feeling? Would you like to talk about it? How has this, at the moment, right now, affected you? Honesty has gotten me through, for 9 years, has gotten me through situations so differently than it used to in my life.
Is this on?
Yep, you're good.
Classically, radiologists hardly interact with patients. They sit in a reading room and they read all the studies. But I started my own practice with a different model because I really wanted to practice like a GP who happens to be a radiologist, so that patients have relationships with, there are 3 of us in this practice right now, and the patients have visits with their radiologist so that they get their examination and then they have a consultation with us and with each doctor that they're scheduled with. And so we go over the results and we do a physical examination, we go over their history, and we make recommendations. So it's constant interaction, getting to know people. And when we do this consultation, we can actually be more diagnostically accurate because we find out all these other clues in the puzzle to help figure out what's going on with the patient and what to recommend.
My professional experience is that when there's a cancer diagnosis, first and foremost, you have to give the patient hope. Because most patients are either in denial or devastated. And that's what I wanted. And so consequently, that's what I give to my patients. I want to let them know, this is what you have. It's not going to kill you. And this is how we're going to address it. And then I routinely let them know that I'm a cancer survivor. And there's a relief there. I mean, when your caregiver has also survived and done well, there's a sense from them that I can get through this as well. So I think having experienced it myself, you just have to, as I said, give the patients hope and then give them a concrete plan that this is how we're going to make you better.
Not much to add. I think the thematic point. Obviously, those of you who sat on the other side of the patient-physician encounter can speak to that. All I can say is the theme of honesty is key, and you want honesty at the time of diagnosis. But when you're healthy, it's not so clear that everybody wants honesty. They want to feel good, and they want to diminish their symptoms, and they may not want to know what their risks are. And one of the great challenges that I found in my later career, which is in the prevention, I used to treat kids with leukemia and lymphomas. That's how I started. And now I'm doing more of this genetics. We need to approach the public with the same honesty about risks and not denial.
Thank you. Dr. Offit, so here's a question for you. Can you speak a little bit about the before study and the difference between that? What's unique and beneficial to that as opposed to something like 23andMe?
So it just happened the day that we started and announced the before study, this company, 23andMe, announced that they were going to take all of their recreational genetics tests that have been done for ancestry purposes and, oh, by the way, send people a little note if they happen to have these breast cancer mutations. And this was done because of a loophole due to the Trump administration's FDA policies, which I won't get into. It was extraordinary that they were allowed to do this for technical reasons. But nonetheless, it sort of set off this kind of different model. One is I've just told you how challenging it is to approach getting testing. And now you'll have people who, oh, by the way, for some recreational purpose, we're going to be told that they had a life-threatening risk. And so everything that we know in social science and medicine tells you this is not the way to do things, right? This is going to cause havoc, uncertainty, distrust, bad news. Now, this particular company, I can tell you, has had $1 billion invested in it, and it's not made a cent. And that will not keep it from going bankrupt because it has got very deep pockets, and it's in it for the very long haul. And you can guess what that's all about. It is a for-profit company, and these companies have a different model than a medical model. Let's just leave it at that. So I would say that our way of doing the testing is the answer to the 23andMe. And yeah, it may seem a little cumbersome, and you've got to listen to the doctor from Harvard, and you have to talk about the risks and the benefits. But that's how you approach making an informed decision as opposed to making a after-the-fact sort of purchase, right? So they're very different, and it's a very interesting contrast. But I'm sorry to say that I think that there's a conflation of this, and our Charchart representatives also have become part of this discussion as well, as a number of individuals with all good intentions have found out this information the backhanded way. And this will not work for us to spread the message in an affirmative, empowering way. Individuals need to understand when they're getting a test what the test is that they're getting. It's just the basic rule of how a medically informed decision makes. These are medical tests. These are not recreational tests. You can hear the range of the options. We're talking about the fine points of the types of the surgery, the timing of the MRIs. These are minor, small, complicated points, but these are life preserving, life-affirming decisions. These aren't recreational decisions. So the models are completely different. They may look the same, but they're really quite different.
So the percentages of people who are walking around with BRCA positive are very high, don't know that they have this gene mutation. So why aren't doctors more proactive about helping patients be reflective about being tested?
We recommend to patients all the time that they get tested. All the time.
Your practice?
Yeah.
Do you feel like that's the norm?
I have no way of judging what other people do, honestly. But it's certainly the norm for us.
Mm-hmm. So, Right.
I just think that it's just ignorance. It's not that they're withholding information from you. It's strictly about ignorance, which is so wonderful about a night like tonight, where we disseminate the information about the BRCA gene. I was ignorant, and here I am, a physician, well trained, 30 years in practice, and I was ignorant as well. So,
in fairness to the physicians, we rely on rules of practice, and Dr. Levy will tell you what recommendations are. She may make some slight differences, but by and large, we have to follow the rules of practice. And the rules of practice are numbers driven. So I could tell you, for example, of prostate cancer, that you have to find 27 prostate cancers to save a life. That's led to one set of recommendations that you and I don't agree with, because we don't think 1 in 27 is a very impressive number, do we? 1 in 40 of you have an Ashkenazi founder mutation. And there's about 30 or so here. The odds are, if this hadn't been selected, one of you would have one of these. The general medical recommendation is that doesn't meet the threshold to screen a population, 1 in 40. To me, that sounds like a pretty high number. So we've decided, as a research study, to make available to all of you that test for free. But your doctor, in fairness, can't tell you if you have no family history. It's medically required for you to have the test. So they're not ignorant or lazy. They're just kind of following along with practice. But at some of our academic centers, we're trying to practice the medicine that's going to be 10 years from now, right? And I can tell you 10 years from now, you'll be tested for all of this, plus things you don't even imagine that you'll be tested for. So why not do it now if you can? So I think the physician community is, they're not. We can't blame it completely on our rules of practice.
I just want to interject. First of all, we're here tonight, and we're telling you should be tested, and that's one of the reasons I'm grateful to Rabbi Gelber for recommending this program. And it's not just the people in this room; it's the people who are watching on live stream, and there's actually a robust number. And this video will be posted as well. And every one of you should go and tell your friends. And that's how we do this. Rabbi Gelber, we have time for one more question.
So we talked about wanting doctors, physicians to treat us with compassion. We should treat our friends with compassion and empathy and wisdom. So there were several people who wanted to know the outcome of Brian's illness.
Brian passed away 3 years after his diagnosis. Unfortunately, once you have metastatic prostate cancer, he didn't have a chance. And I don't know if Brian was BRCA negative or positive, but the fact of the matter is that he passed away, at in early age. The goalposts keep changing when it comes to testing. I can give the recommendation now for colon cancer screening is now 45. Well, it was 50 for many, many years. Right, a month ago it was 50. Well, that should make you think, well, why did they change it to 45? Well, that's because there were all these people dying of colon cancer between the age of 40 and 50 that now they've changed the goalposts, so now it's 45. Well, the recommendation right now is not to get your PSA checked at all. And how many of us are going to have to develop prostate cancer and die, and 10 years from now, whatever number it is, everyone's going to be recommended to get it at a certain age.
So I want to thank our incredible panel. Thank you all very much. Just a few brief announcements. One, the most obvious is, if you haven't been, sign up for the test. Get tested. Tell your friends to get tested. Everybody who's watching either live stream or when you're watching the video, sign up for the test. As you leave, there are brochures, and there is a volunteer from Sharsheret, which is a Jewish organization that actually helps with cancer information. They're out there to help you sign up. I know that the before test also has someone out there to help you. And if you want to get a copy of this really extraordinary book, you can head out this way for a moment, and Letty will be there selling and signing books again, actually at a very nice discount now that I see the retail price. We don't do retail here.
Only if you signed up for the test, she'll sign.
There we go. So please take advantage of the information outside, take advantage of the free testing, and get a copy of the book. Thank you very much for coming.